Fatungase, I'm sorry for pronouncing the name in that, who is a fellow of both colleges, the National Postgraduate Medical College of Nigeria and West African College of Surgeons, Faculty of Anaesthesia, a consultant anesthetist since 15 years till date at Olabisi Onabanjo University Teaching Hospital, a versatile anesthetist with great passion for service delivery and training, hence her appointment as the CMAC of that institution about 2 years ago. She is also an examiner with the Faculty of Anaesthesia, National Postgraduate Medical College of Nigeria. Please, Ma, you are welcome. Please, are you ready for your presentation, Ma?
Yes, I'm ready. Good afternoon.
Thank you, Ma.
Okay, can I go ahead now?
Yes.
So I wish to thank the executives of NSA for this privilege granted me, and Dr. Briggs and her team for this opportunity. I'll be talking on principles of geriatric anesthesia. I wish my slides be displayed now. Okay, so I'll be talking on principles of geriatric anesthesia. And I'll be going through this outline, the introduction, the common surgeries frequently encountered by or done by the elderly, the age-related physiological changes in various body systems, anesthetic considerations, preoperative evaluation, anesthetic techniques, general anesthesia versus regional, day case anesthesia, and anesthesia outside the OR, postoperative care in the elderly, and then I will conclude. Shall we go now? The geriatric age is defined by the UN to be age 60 years and above, chronologically versus physiological. And WHO also defined from age 65 years and above. But you would agree with me that in Nigeria, most people in the public service are made to retire at the age of 60 years, which is seen as the year of, the age of retirement. And maybe the government sees, or the general population sees it as an age that productivity would have dropped. People would have served the government for over 30 to 35 years by that time, except for those in academics who perhaps stay to 70 years. Now, there are different classifications, but even for the elderly, there's youngest old from age 65 to 74 years, middle old, 75 to 84 years, and the oldest old as above 85 and above years. And aging is a physiological process clinically characterized by degenerative changes in the structure and functional capacity of both organs and tissue. And there's limitation of physiological reserve in such age group during times of stress, particularly anesthesia and surgery. And you all agree with me that we all desire to grow old and become, age gracefully. Now, the elderly are vulnerable and especially sensitive to the stress of surgery and anesthesia, and they have increased incidence of severe complications during perioperative course. I'm on the second slide, please. And mortality rates related to surgery is approximately 3 times higher for patients above 75 years old. Morbidity and mortality is even worse during emergency procedures. Technical, I've gone beyond this slide that is currently in display. I'm on the third one. Please, can you move along with me? Thank you. And the main goal of the principles of geriatric anesthesia is to ensure speedy recovery for such age group and avoid any form of functional decline in them, because already they are structural and functional decline. And the outcome of surgery and anesthesia is directly related to the care they receive during the perioperative period. So one must anticipate complications in them. One must, have good knowledge of whatever comorbidity they're coping with, or perhaps will be discovered at the preoperative evaluation assessment period. And such must be taken care of, well optimized to have a good result. and alteration in techniques of anesthesia, considering age-related changes to normal physiology, even in the absence of a specific organ-based disease process, must be put into consideration. Now, common surgeries that will probably come in contact with such elderly age group, maybe cataract extraction. I'm sure some of us would know that most of the centers, they have cataract extraction under local anesthesia. But some rare cases when they have maybe, let's say, hearing defects, they have like disabilities, they have maybe some kind of delirium, they might need an anesthetist to give monitored anesthesia. I've had to do such for like 2 or 3 before, some years back. And hip fracture surgeries, TURP, cystoscopy, pacemaker insertion, carotid endarterectomy, hysterectomy or hysteroscopy, and this list is not exhaustive. So we can meet them outside the OR or even within the OR. So let's go to age-related physiological changes in the elderly. Now, in the cardiovascular system, they have atherosclerosis and increased arterial wall thickness. And there's decrease in the extent of autonomic control of the cardiovascular system. They have reduced cardiac output, systolic function could be markedly conserved, and cardiac responsiveness to adrenergic stimulation is markedly decreased at this age group. So baroreflex responses, they are unable to completely maintain hemodynamic stability in stressful conditions. And so they are predisposed to orthostatic hypotension and administration of vasoactive drugs. Decreased functional capacity of organs and then worsened by coexisting diseases. At this age, rarely will you find any one of them without any comorbidity. They either have hypertension, long-standing hypertension, or diabetes, or some form of peripheral nerve neuropathy or such. Now, subsequent decrease in autoregulation of blood flow to kidney and brain also would have set in at this time. And it's even usually said that from age 40, there's decrease in the function of most organs in the system. And that's why our lifestyle change has to start from that age. So by the time we get to the elderly age group, we're probably in a better shape to face the challenges of that age group. So impaired physiological response to stress due to decreased autonomic function. And diseases like ischemic heart disease, hypertension, diabetes, hypercholesterolemia, they are common in geriatric patients, and myocardial thickening and diastolic dysfunction. So one must anticipate this and must be ready to combat it or even manage it with them. Because sometimes when they come in for surgery, it's not something you can shelve. You either reschedule them if it is an elective and plan well for them. But if it's an emergency, you probably be between the devil and deep blue sea, and they still have to be managed. So age changes both pharmacokinetic and pharmacodynamic aspects of anesthetic agents in this age group. What are the clinical implications of this? We have to have all this in mind, and so they cannot, tolerate or compensate well for hypovolemia. And they are like, extremes of age, either the too young or the too old, or very old rather. So one must avoid hypovolemia, and at the same time, we must avoid fluid overload in them. And cardiac monitoring is essential perioperatively. So cardiac monitoring for such age groups is not negotiable. ECG monitoring particularly must be done intraoperatively for them. Their respiratory systems, their chest wall is rigid. And so there's reduced strength of respiratory muscles. Lungs are more difficult to ventilate and decrease in maximum inspiratory and expiratory force. There's decreased alveolar surface area, and then there's decreased residual volume in them and increased closing capacity. Thus, subsequent alveolar hypoventilation, hair trapping, leading to ventilation perfusion mismatch. And so they are prone to hypoxemia easily, atelectasis in them. So the prevalence of COPD intensively increases with age. Atelectasis, chronic bronchitis, pneumonia, and pulmonary infections are more common in these patients. And the combination of these several events predisposes them to hypoventilation and respiratory complications, such as residual effects of anesthetic agents, prolonged effects of neuromuscular blocking drugs in them, post-operative surgical pain, which may not allow them to breathe easily, and so any comorbid respiratory disease. All this has to be put in mind, particularly when they have any surgery that is related to the chest, or even any part of the body in which they are not adequately, they're not given adequate pain relief. This will further worsen the respiratory reserve. So what are the implications of this? Adequate pre-oxygenation must be done for them. And post-operative supplemental oxygen is strongly indicated either at the PACU or HDU or ICU. And they must be pre-planned and then must be available for them. The multimodal analgesia should be planned for. They are not a good candidate for so much of parenteral analgesia, to go into the system. One can combine peripheral nerve blocks, infiltration, and some other forms of analgesia that will have less effects on their central nervous system. And chest physiotherapy should commence earnestly, and early ambulation must be recommended or encouraged where applicable. Now let's go to the kidneys. Now it's said that renal mass decreases per decade. That is every 10 years, there's a decrease in renal mass. And by 80 years, the kidneys itself has lost about 30% of its value. And renal blood flow decreases about 18% per decade. So there's a progressive decline in creatinine clearance with age. However, serum creatinine level remains stable due to a reduction in muscle tissue. So it is not a good predictor of renal function in the elderly. So because one does electrolyte angiuria for an elderly and the creatinine value still remains within the normal range, does not mean their kidneys are functioning effectively. So one should still not overload them because they cannot handle high sodium load and too much of fluids. They're so important in proper dosage adjustment for medications that are excreted by the kidneys. Is that we avoid drugs that will have to be excreted by the kidneys, or you use limited quantity of these dosages for them to avoid any form of morbidity or mortality in them. Now they have high risk. The risk factors for acute postoperative renal failure in them are advanced age, presence of diabetes mellitus, pre-existing renal insufficiency, major vascular surgery to be done on them, or recent exposure to nephrotoxins that has compromised their kidneys. And risk factors for subclinical renal insufficiency are sympathetic stimulation, pain, surgical stress, and the use of vasoconstrictive drugs. My slides are not showing again to everyone. Technical support, please, is needed. Now, what are the clinical implications for this? They have impairments of sodium handling and concentrating ability and diluting capacity, of course, has been impaired at this age. And it is worse with increasing age from age 65. So this predisposes the elderly patient to dehydration and fluid overload. So one must intentionally maintain a balance. Monitoring input and output in them is compulsory, no matter how short the procedure is going to be in them. And reduced blood flow, renal blood flow, and decreased nephron mass, increased risk of acute renal failure in the post-operative period. It's generally said that in the elderly patients, they're highly prone to acute renal failure immediately after post-operative. Is one of the common or expected complications if one is not, anticipating it and then ready to combat it. So dosage requirement for both local and general anesthesia must be reduced in them, and delayed recovery for anesthetics should be anticipated. And this would predispose or probably come up due to prolonged drug effects in them. The central nervous system. Most of our anesthetic agents, target the central nervous system. Yes. So memory decline occurs in greater than 40% of individuals older than 60 years. In fact, for women from age 55, due to menopausal changes, most of these women, my slide has gone far beyond. You have to go back some few slides I'm still on central nervous system. Thank you, technical support. Okay, so what I was saying before is that there's a memory decline. I'm on slide 18. That could help you. Yes, memory decline occurs in greater than 40% of individuals older than age 60 years and dramatically affect performance of activities of daily living. And I was trying to say that even for women from age 50, 55, once perimenopausal symptoms start, we start experiencing memory decline, forgetfulness, and all this set in. Now imagine from age 60, 65, 70, 80, you should just be ready for whatever happens. And so this has to be put into consideration, even when they are being reviewed for doing preoperative anesthetic review in them. There's significant regional reduction in neurotransmitters in them, dopamine, acetylcholine, norepinephrine, and serotonin. Now, because of decrease in brain reserve, they will manifest decrease in functional activities of daily living. And that's why you see the elderly at this age, they are slow at speech, slow at movements, slow at doing things. So one has to just take it up like that and has to be patient and loving and caring to attend to them. Thus, decreased dose requirement for intravenous and inhaled anesthetic agents is important. There's increased risk of perioperative delirium. So one has to be cautious of whatever drug is to be administered to them. And there's increased risk of post-operative cognitive dysfunction in them. One must anticipate this and quickly identify once one sees any traces of this. Neuroaxial changes include a reduction in the area of epidural space. Thus, expected epidural anesthetic may result in more cephallar spread in them. Whereas the duration of blockade or the strength of muscle paralysis may not be as strong as expected. But however, they are at risk of complications of cephallar spread. So one must give them still a reduced dose. And there's increased permeability of dura and decreased volume of CSF also in them. So the diameter, so if you have an elderly patient, let's say is 85 kilogram body weight, one should not give the expected dose or the calculated dose for a 40-year-old, a 35-year-old that is also 80 kilogram. They have a high risk of cephallar spread because of the compartment that they have or the problems, neuroaxial changes they have in the epidural space. Now, the diameter and number of myelinated fibers in the dorsal and ventral nerve roots are decreased in the elderly. Peripheral nerves interstrand cell distance is decreased, and including conduction velocity in them. These changes tends to make elderly individuals more sensitive to neuroaxial and peripheral nerve blocks. So it is preferable to run into regional techniques, though it is not a total way of escape. One must try to balance in making sure they have, good care. Now, dosage requirement for LAs is reduced in them. So given volume of epidural anesthetic may result in more cephallar spread. I think I just mentioned this, and then longer time to recover from general anesthesia. And then they have issues of disoriented, delirium perioperatively. They are sensitive to centrally acting anticholinergic agents. Sometimes they manifest, or most of the extrapyramidal, side effects. And post-operative delirium is common. Incidence less with regional anesthesia with sedation. So it is still best to give them regional anesthesia where the procedure is amenable to it, or use local anesthesia, peripheral nerve blocks in them. So let's go to temperature regulation. Temperature regulation is difficult in the elderly, and I'm happy we've had a previous talk on or teaching on temperature regulation this evening, because they have reduced subcutaneous fat and decreased ability to sweat. They are more prone to hypothermia. So they have to be taken care of. We have to watch out for it. And immediately once they get into the oral, they should be kept warm. And temperature monitoring should compulsorily be monitored in them, because when they are prothermic, they have the drugs that are naturally will be prolonged in them will be further prolonged. And so they have a high risk of delayed awakening from anesthesia. So maintenance of body temperature is essential in the perioperative period and should start as soon as patient enters the OR. The elderly lack the metabolic and muscular reserve to bring their body temperature back to normal levels. One must anticipate this. GIT, hepatic and endocrine dysfunctions. The liver volume is approximately 20 to 40% reduced with aging. And then hepatic blood flow also decreases by 10% per decade. And so there's decreased hepatic blood flow, which influences clearance of drugs that depends on hepatic metabolism. So we have mentioned that any drug that passes through the kidneys or passes through the liver or is excreted through any of these two organs must be used in minimal volume or dosage in them. Then they have decreased gastric emptying. So you must also treat them as full stomach. And there's increased incidence of diabetic mellitus in them. So if they are also diabetic and they are elderly, they are double risk for full stomach, whether they're coming for elective or emergency procedure. Pharmacology and drug metabolism changes. Now, factors that affect the pharmacologic responses of elderly patients include the plasma protein binding. Alpha-1 acid glycoprotein level is increased. So binding protein, and this is the commonest binding protein for basic drugs in them. Then we have to put into consideration the body content, and then the drug metabolism is also altered due to renal and hepatic changes, which I mentioned earlier on. Now, they are also highly sensitive to anticholinergics, particularly atropine. So atropine must not necessarily be a premedicant in them. You can use other alternatives and also still use other alternatives with caution in them. Then the main plasma binding protein for acidic drugs is albumin, and the basic drugs is alpha-1 acid glycoprotein. The circulating level of albumin decreases with age, whereas for alpha-1 acid glycoprotein, level increases. So the effect of alterations in plasma binding protein on drug effect depends on which protein the drug we are using is bound to, and the resulting change in fraction of unbound drug. Now, there's a table next that just summarizes the brain sensitivity and pharmacokinetics and what you should do with drugs. Next slide, please. For inhaled agent, inhalational anesthetic agents, their brain are very sensitive and can easily be suppressed. The next slide, please. Next slide. So doses of this has to be reduced. That is, the MAC has to be reduced for them. For thiopental, there's really no brain sensitivity much, but for the pharmacokinetics has to be put into consideration, and so dosage also must reduce for this. Etomidate, same, but volume must be reduced, and so dose must go down. For propofol, there's increased brain sensitivity in them. The clearance is low in them, and so dosage must reduce. Midazolam, they are also highly sensitive to it, and so clearance is also low in them, and so dosage must reduce. And also for morphine, they have high brain sensitivity. So generally for opioids and for benzodiazepines, one must be highly cautious with the use of these drugs in them. So the minimal alveolar anesthetic concentration, decreases approximately 6% for every decade in this elderly age group. And they are more sensitive to anesthetic agent, thus give smaller doses for same clinical effects, and drug action is often prolonged. At this point, I just want to mention that there was an incidence heard of a patient. And I always tell my residents, anytime you want to give the elderly any drug, you give slower than you will give to any other able body, and you must dilute the drug and give slowly with patience and see the effects. They don't necessarily need to get 30 milligrams of pentazocine for pain relief that would give them adequate pain relief like another able-bodied 50-year-old. There was this incidence of a patient that was having, meant to have burns dressing on the ward. And the house officer gave IV pentazocine. He just gave it push, pam, and the poor woman died. She didn't die of what she brought into the hospital. She died of inappropriate administration of drug. So anytime I even meet house officers, the one thing I always tell them, I live with them, and even medical students, is that any IV drug must be given slowly. And particularly when you're not giving it to an elderly, give it extra slowly. Because we all desire to be old one day, and we don't want to die of any form of avoidable death. And every elderly must be handled or seen as, this could be my mentor, this could be my father, it could be my grandfather or grandmom. So we should all be considerate in handling them. So what are the general anesthetic considerations in them? There's increased prevalence of coexisting comorbid illness, which must be optimized before surgery in them. You must look out for it. Some come even from the village and say they have never gone to hospital, have never used any drug. Still run the test through them, and you might be shocked that they might have been living with hypertension for a long time. There might be need for caregiver when taking history, because we mentioned that the brain mass decreases every decade. So they must have lost information. They might not even remember they're hypertensive or even taking any drugs. They might not even be able to mention the drugs they're taking. So it's always good to compare notes with a caregiver who is, clear-headed enough to give us better information about them, so that we will have that to work with. Informed written consent must be obtained because of memory decline, which may occur in greater than 40% of this age group. Peripheral venous access may be difficult due to lung tortuous, thickened blood vessels. And for heaven's sake, anything that has to do with geriatric anesthesia, one must ensure tender, loving care and must be patient and make sure your first attempt is your best attempt in them. When you keep on pricking them, you aggravate them the more, increase the anxiety, and you increase pain in them. And that is not desirable. So there's increased risk of hypoxemia when lying supine due to reduction in functional residual capacity. So they are candidates for pre-oxygenation during induction of general anesthesia, and supplemental oxygen is administered during regional technique for them. And co-induction is preferred in general anesthesia because response to most induction agents may result in exaggerated fall in blood pressure, except for ketamine. So if you are using a bit of propofol, you can use a little bit of midazolam, and then just use a bit of here and there and be able to achieve what you want in them. There was a time I needed to anesthetize an elderly, I think an 80-year-old, thereabout engineer, retired engineer, who has never in the last 40 years used any form of orthodox medicine because he reacts to a lot of drugs, even to paracetamol. And he was meant to have cataract extraction bilaterally at a private facility. I could barely sleep the night before because I thought of which drug would I know this man will not react to. And technically what I did on that day after reviewing the man, his blindness from cataracts made him more anxious. And of course, at that age also, he had some bits of hearing defects, so he could barely hear well. So I had to make contact with him. I touched his hand. I had to allay his anxiety by words of reassurance. I did psychotherapy for him. And I had to just play around with a little bit of midazolam. I couldn't, go into any form of deep sedation or general anesthesia for him. And I had to relate with the surgeon, the ophthalmologist. I told him I would speak with Baba and I will allay his anxiety because he reacts to a large number of drugs, and there are some he still discovers sometimes when he uses. So he doesn't use any form of drugs for any illness at all. He has his own botanical garden where his wife plucks herbs for him to use. Apart from that, he doesn't use any form of prepared or processed drugs. So that was what we used. I laid his fear. I gave him a very little pediatric dose of midazolam. He slept off. He held my hand all through the surgery. And then they gave him a block. I told him they were going to give him a block in the eye. It will make him pain-free, and he cooperated. So as soon as the block was, and luckily the surgeon was a very fast ophthalmologist, He finished up his procedures in 20 minutes per eye, and it was done. So less than 40 minutes, we were done with the 2-eye cataract extraction, and it was a good ride all through. So then co-induction is preferred in general anesthesia, and then we are meant to reduce the dose of pre-medication in them. Let's go to the next slide. Proper dosage adjustment for medications that are metabolized by liver or excreted by the kidney, e.g. opioids, neuromuscular blocking drugs, benzodiazepine, etc., because there is associated renal mass reduction by 30% at the age of 80. And of course, if it's the age of maybe 70 or 60, we also expect some percentage reduction. Increased risk of fluid overload due to poor sodium handling, concentrating ability, and diluting capacity. Neuraxial blockade minimizes the risk of common postoperative side effects seen at, when general anesthesia is given to them. So things like postoperative cognitive dysfunction, pain, fatigue is avoided when we give or we administer general anesthesia. So if our procedure, whatever procedure they must have, is amenable to a regional technique or any form of other peripheral nerve block, one should just go for it and give minimal or monitored anesthesia with minimal sedation. Regional opioids are safer and preferred to parenteral opioids in them. Next slide. Preoperative evaluation. In them, two principles must be kept in mind. First, the disease process that are commonly associated with aging, hypertension, diabetes, ischemic heart disease, all those things. And second, one must assess the degree of functional reserve of the patient. And common diseases have a major impact on anesthetic management and require special care in them. So evaluation includes airway, blood volume, skin. We mentioned that certain line could be happening tasks in them. So the risk assessment depends primarily on 4 factors. Number 1 is the age. Once they are age 60, 65 years and above, they are at risk of some morbidity, some degree of morbidity or mortality. Then the patient's physiologic status or coexisting disease, based on the American Society of Anesthesiologists physical status, classification. Then the type of surgical procedure, I'm on the second slide, I'm on the next slide. This type of surgical procedure, whether it is elective or elective cases will give us enough time to thoroughly examine them and investigate them. But for emergency, we might not have such opportunity. And they have ×3 risk of morbidity or mortality when they are being handled on emergency cases. So one must be extra cautious and extra careful in handling them. So, and then the type of procedure. The more invasive the procedure, the more prolonged the procedure, the more advanced the procedure, the more risk that one might have with them. So one must put this into consideration in handling them. And anesthetic complications are related to age. With increasing age, there are more risk. The surgical mortality increases also with age, generally. There's increasing age. The increasing age is an important predictor of adverse perioperative events. Airway assessment. The presence of vertebral basilar arterial insufficiency is evaluated by determining the effect of extension and rotation of the patient's head on mental status. Poor dentition. Majority at that time have dentures or loose tooth or might even be edentulous. And so this poses difficult intubation in them, and this has to be put into consideration, anticipated, and then one be prepared to handle such with a technique of laryngoscopy. Cervical osteoarthritis or rheumatoid arthritis may interfere with visualizing the glottic opening. And if one has access to fiber optic, one could use it. But if not, we use what you have around, but be sure that you prepare for them. And because they are elderly, does not mean at the age of 90, if you have to anesthetize, such patients should be condemned to death, that whatever happens should happen. One should give them, because every aged is precious to the ones that they are, to their loved ones. So they must be handled as such. Blood volume. Elderly patients are often volume depleted. And this is reflected with decreased thirst. There's age-related decreased renal capacity to conserve water and sodium along, also. So there's frequent use of diuretics in them. So if they are hypertensive, they're on diuretics, and they don't have the thirst, the sense of thirst, in them, they are high risk for dehydration, and one must not allow them to be dehydrated. So one can assess for it. So as part of optimization, one should hydrate them, but one must not overhydrate them. Assessment of intravascular fluid volume is important prior to induction. Now, nutrition, significant possibility of malnutrition and immobility could be seen in them. Due to pain or arthritis, they may not be mobile as expected. Now, in positioning them, because they are skinny or they have prominent bones because of poor nutrition for any reason whatsoever, one must protect pressure points to prevent development of sores, bed sores in them. And one must determine the cognitive status in this patient. And please document, make sure you assess and document in them. If it is not documented, then it was never done. Cognitive deficits are associated with poor outcomes and higher perioperative morbidity in them. Pre-medications, lower doses of pre-medicant, I think we've mentioned this before, and anticholinergics if required, glycopyrrolate, which does not cross blood-brain barrier, can be given to them. S2 antagonists are useful to reduce the risk of aspiration in them. And metoclopramide can also be used to promote gastric emptying. However, the risk of extrapyramidal effect is higher in these patients. Now, choosing between anesthesia techniques, general anesthesia versus regional. If regional technique is voted for or is preferred technique for them, there is decrease in the incidence of deep brain thrombosis after total hip replacement because they will be less immobile. They'll stay, they will be ambulant early and may be associated with reduced blood loss in pelvic and lower extremity operations if regional is done, and does not require instrumentation of the airway. So the risk of dislodging any tooth, airway obstruction, and problems with intubation will be avoided. Then patients maintain their airway and pulmonary function, if regional is done, and then may have a lower risk of hypoxemia. But despite that, we've mentioned earlier that even when they're having regional techniques, supplemental oxygen must be given to them. Maintenance of consciousness during surgery permits prompt recognition of acute changes in cerebral function or the onset of angina pectoris. So it is important that ECG, all the basic monitoring must be done in them. And at the same time, you communicate verbally with them to allay their anxiety so that you can have a good outcome for, post-operatively. Regional anesthesia does not seem to decrease the incidence of post-operative cognitive dysfunction compared to general anesthesia from studies that have been done. So this is not an absolute escape. Anything could trigger it in them. So one must still watch out and be careful and also give them tender loving care. General anesthesia carries greater risk, and regional anesthesia could provide an excellent solution to this. Peripheral nerve blocks promises a favorable outcome in them. Airway is not compromised. There's no risk to major, the hemodynamic effects, and peripheral nerve blocks have shown to last, in them, not to last so much long in them. Then choice of medication, consider changes in organ system function associated with age. Altered responses to drugs, pharmacokinetic and pharmacodynamics is to be put into consideration. Cardiac outputs and delayed clearance of drugs, slow onset of drugs effects in them. So that is why when you are administering drug to them, don't be in a hurry. Patience is always a virtue in administering drug to them. I'm on slide 39. So patience is a value when administering, attending to geriatrics for any form of anesthesia. There's risk of, slide 40 now, risk of anesthetic overdose, especially volatile anesthetic agents, and combination of decreased anesthetic requirements and decreased cardiac output worsens this. Hypotension during the induction of anesthesia could be worsened or precipitated by decreased sympathetic nervous system activity and balanced volume replacement vasopressor as indicated. Then they sometimes may not come majorly into the OR. We could meet them as day case or outside OR care. Maybe they have to go for MRI, CT scan, or dental extraction And not all elderly patients are eligible for this, day case procedures. For example, the man I mentioned to you that needed cataract extraction and reacts to a lot of drugs and needed to be, carefully handled for a successful surgery. So each patient has to be considered on an individual basis. So the goal is to use short-acting agents and careful selection of drugs in them. Ensure lower effective doses to obtain desired results. Be patient and show empathy, that is TLC. And adequate pain care is compulsory in the elderly. Avoid postoperative nausea and vomiting. And in fact, if they have any traces of such, you cannot discharge them. So discharge criteria from day case must be applicable in them to avoid agents that could predispose to delirium or cognitive dysfunction in them. All this has to be put into consideration, whatever form of anesthesia one has to give to them. Postoperative care in the elderly is a must be planned for. The success of any surgical procedure depends heavily on the skill of a surgeon and the quality of the recovery time. And of course, the skill of the anesthetist must work together as a team, must be pre-planned. Post-op care must be pre-planned in them. You either want to take them to PACU or high dependency or intensive care. And all this, you have to take care of pain with multimodal analgesia, supplemental oxygen, close monitoring in them so that we can have a good outcome in total. It must be a good package envisaged for them. So before you can discharge them from day case, ambulatory care, they must meet the discharge criteria, and particularly please note that it is not safe to discharge an elderly with instructions only to go home. There must be a caregiver who will take responsibility, that can write down instructions and handle them, because they might forget instruction by the time they get home and they won't be able to, take care or handle whatever it is they're going through. In conclusion, there is need for exquisite attention to details in managing elderly surgical patients, and comorbidities should be factored into the perioperative risk assessment of the geriatric patients. Those are my references. I wish at this point to acknowledge the contribution of my mentor and coach, Professor Olaitan Soyonwo, and of course the good support I received from Dr. Toyin Shoyemi, my senior registrar in the Department of Anesthesia. Thank you so much for listening. Can we watch slide 46 as we round up and expect questions, please? Slide 46. Slide 46 is before thank you.
Kelechi, uno na-abanye n'ụgbọ big jen ọnụ, uno buy big jen ọnụ akwa mmiri.
Please, can you all mute your
speaker?